Hello, welcome everyone. Thank you for joining us today, and we appreciate your time with us here and hope you find it valuable. Today, we're going to be implementing evidence-based programs for diabetes care. And my name is Maria Bustamante, as Lisa said. I'm the Health Initiatives Program Manager for the National Center for Farmworkers Health. And for those of you who may not be familiar with NCFH, we are a private nonprofit organization. We're located just outside of Austin in Buda, Texas. And our mission is to improve the health of farm workers' families. And we do that through supporting different initiatives and training and technical assistance through population-specific data resources, workforce development and training, health education resources, and program development, as well as many other things that we do. We also have our Ag Worker Access campaign. I highly recommend you looking at this program if you haven't done so. We're part of a national initiative to increase the number of migratory and seasonal ag workers and their families served in community and migrant health centers. So it's very important that we are able to record how many of our patients are actually migrant and seasonal ag workers and their families, so that we can secure funding for that and that we can continue the work and support that we give them. So today we're going to be going a couple of learning objectives. We're going to be going over what is a DSMES, diabetes self-management, education support programs, and diabetes prevention programs, and going over how they connect with our diabetes quality measures that we all usually keep at health centers and different health settings, and going over a couple of tools and strategies for successful implementation and what's needed for it, how you can start your programs. So first of all, I wanted to start today, November 14th, with recognizing that today is World Diabetes Day, and kind of celebrating yourself and making sure that we tell our story. You have to be able to tell your story to be able to share your successes and challenges and everything that you do on a day-to-day basis to support people with diabetes and to help your community. So a big celebration for all of you. I know that all of you work really hard with your persons with diabetes and supporting them. As we all know, diabetes is a significant global challenge, not only here in the US, but globally. And it is affecting the health and well-being of so many people, families, and countries. And we must turn our word into actions to provide affordable and uninterrupted access to diabetes care for all. So working with our patient population who has diabetes, we have known and seen the high prevalence of diabetes and pre-diabetes. This number of people, the rise is only continuing on, and it's putting a lot of pressure on healthcare professionals such as yourself. And it's making us think more efficiently. So we have limited time and we must provide the best possible care and support to the millions of people who are affected by diabetes. So it's putting a really high pressure on staff and on yourself, and forcing us to work efficiently and more innovative as well. There's a high need for improvement in the prevention and treatment of diabetes. We know that 1 in 10 people, Americans, have diabetes, which is a huge number. And even bigger than that is in that 1 in 3 have pre-diabetes. So if you look around you and the people around you, if there's 3 people, the probability that there's one of them with pre-diabetes is high. So this is data according to the Centers of Disease Control and Prevention, CDC. And it's just been released also some more statistics that there's and Megan is going to share it. Megan shared it in the chat. It's an ADA article of the economic cost of diabetes, the American Diabetes Association. They just released this a month or so ago, and I thought it was important to showcase that in the highlights that they discovered, and the numbers are just astronomical. The total annual cost of diabetes has reached $412 billion, billion with a B. A staggering 1 out of every 4 spent in healthcare is now allocated for individuals with diabetes. And what's most shocking here is that cost of diabetes on one person. Diabetes results in an additional $12,000 in healthcare expenditures annually per affected individual, which is, if you can imagine, what is the average salary of a person and the average income, and having to put out $12,000 a year additional to your healthcare premiums and etc. This is no wonder why there's so much difficulty, and the expenditures are really a high cost for people affected with diabetes. So it only makes our case even stronger that we have to address this problem before it starts, right? So prevention.
Maria, we do have a question before we go on to the implementation of programs. When referencing these statistics, are we mainly talking about type 2 diabetes or?
Yes, they're referring mainly to type 2. Oh, actually, that is a really good question. I do not recall, but the article has been shared in the link, and that is a really good question. Thank you for that. You can look over. I'll send the response also afterwards. And Megan, I don't know if you can kind of look over the article. I didn't specifically look for that. So I wonder now myself. But we do know that diabetes type 2 is the most common one. So I would say that a big percentage of this is diabetes type 2, if not only. But yeah, good question. Thank you. And it is staggering numbers either way. I don't know. It's impressive. But we thought we could start today looking at, yeah, thank you for that. 95% are type 2. Yeah. So we have a really good group here today. So we're all learning from each other, and I appreciate that. That's the best. Going back to the presentation, and we have a diabetes action plan roadmap. Why do we start with this? We all work in diabetes, and we all work on different things. We have to make our work, as I said at the beginning, we have to work smart. we are already doing some things that we're probably not getting the recognition. Look at what your organization is already doing. what your organization's goals are, and look at your personal goals as a healthcare professional and see where those match. We can adapt our diabetes improvement plans to those goals. Every health center has to have a diabetes improvement plan, and those are tied to our UDS data, right? Our metrics. So look at those and see how we can work on what our goals are, and at the same time work on the things that we're already required to work on. So it may be bringing getting people diagnosed, right? It may be getting those blood glucose under control. So look at that, see what works for your organization, what works for you, and implement that. The Diabetes Action Plan serves as an avenue to create tactics to preemptively decrease the prevalence of diabetes. So what do we do in that? We create frameworks for organization activities. We create care models. So a chronic care model is a great example for that, right? We are addressing diabetes through that model. Quality improvement teams. We have grown even day by day more used to working with quality improvement teams, and quality improvement is embedded within all of our work nowadays. The same for plan for implementation. Evaluate. If we cannot evaluate our programs, we don't know if what we're doing is successful or not. We may know it, but we need to share it. We need to show it, right? And that will bring the sustainability that is needed. So what is the common link between diabetes prevention and diabetes self-management with our diabetes improvement plans? That would be where the quality improvement alignment falls under. And that is going to be your A1C measure, most generally. The A1C measure is a clinical quality metric that aligns across all the different incentive programs, the different payer incentive programs. So the DPP program includes a minimum of 35% of participants having blood-based tests indicated pre-diabetes, right? So you're working on reducing that A1C level in DPP programs. The same goes for DSMES programs. You're working with participants and patients who are diagnosed with diabetes and who may have an uncontrolled blood sugar levels. The most common thing is that we're working with the uncontrolled ones, right? It would be great to be able to work with, everyone's under control and we just help everyone maintain their levels. But we all know that's not usually the case. So we start with those uncontrolled and bring those levels down and include that quality improvement there so that it aligns with your health center goals and with your own personal goals and your quality improvement. So think about what you are doing to improve diabetes outcomes right now. I'm sure you're already working on so many different things. They can be kind of put in two different buckets, right? We have prevention and we have treatment. So we can be fighting this diabetes epidemic either on prevention or in treatment, and we have to determine where our focus or the focus of our efforts are going to be. Again, remembering time is limited, so we have to be realistic and know where do we want to start. Maybe we already started and we want to put something additional complementary in place. So you already are running that marathon and you want to really put that velocity in. So that's another thing. So determine where you are on this efforts and what aligns best for you. Let's go into what the diabetes prevention program is. So the program goal is to make it easier for people with pre-diabetes to participate in affordable, high-quality, lifestyle-changing programs. And this is the key, right? Lifestyle-changing programs, you're going to see it across the whole spectrum. So it's all based on those lifestyle changes, whether you attack the diabetes epidemic on the prevention side or in the treatment side, before or after. So that's the main difference. The lifestyle changes programs, they reduce the risk of type 2 diabetes. People who participate in the lifestyle change program may reduce their risk by developing diabetes by more than half. So it was a really successful program, and that's why the diabetes prevention program, it was implemented, and it has a lot of support and evidence-based success on bringing the participants' body weight down by 5 to 7%. So that's the focus. A key part of the National Diabetes Prevention Program is the Lifestyle Change Program. As I said, it's based off trained lifestyle coaches. It has an approved curriculum, which is evidence-based, right? And we use group support to deliver it and to get that peer interaction over a course of a year. So it is a year-long program. That is something to consider, knowing your population, knowing your retention on past programs, retention rates, can give you an idea of whether this is a good program for you or not, or if your population is very mobile, then maybe this can be a program, but you may have to incorporate some additional components, such as the telehealth part, right? And the program eligibility to participate in a CDC recognized lifestyle change program, you need all of the 4 components, all of the 4 requirements. You need to be over 18 as a patient or participant. I mean, you need to be over 18. You need to be overweight according to your BMI. So it's a BMI of 25 or higher, or 23 or higher for Asian Americans. Not be previously diagnosed with diabetes, and not be pregnant. So you will need to meet one of the additional requirements, which is have a blood test with diagnosed with pre-diabetes, or you have had to have gestational diabetes, or you're at high risk on the pre-diabetes risk test, which is available. The risk test is available in the website, the CDC DPP website. And Megan, it's in the link, it's in the notes. I don't know if you can share that link as well.
Yes, let me get it and I'll pop it in the chat.
Thank you. So there's no referral needed for this program. Participants can attend the National Diabetes Prevention Program with no referral. They can self-refer, but they do have to have those metrics just described. it is covered by Medicare and Medicaid has to be in some states. And NCFH developed an information page resource that Megan just shared in the chat, and this shows this slide comes from there. There's a lot of more information in the resource, but I wanted to highlight the benefits of DPP, of a National Diabetes Prevention Program. And not only the benefits for the patient, but also for the health center. So we have to recognize that programs have to be sustainable, right? And they have to match the goals of the health center as well. So following that thought, you need to see us at both benefits. So patient benefits, the early detection and treatment obviously lowers the risk for diabetes and heart disease, stroke. There's support from a coordinated care team. So the care team plays an important role in this program, and they also address the social drivers of health and connect people with, those needs that they have. There's also a high opportunity to include CHWs in this model as well. You have increased access to evidence-based interventions to improve health, so it's been proven. Why reinvent the wheel, right? For the health center benefits, there's increased revenue through a billable service. So DPP is billable through Medicare, Medicaid, and most payer-based. So it's integrated into the diabetes care team that connects patients to their care they need, including blood glucose testing, blood pressure monitoring, and whatever other services you may have in your health center that are supplementary or complementary, such as behavioral treatment or nutrition or many others, right? Even dental. You obtain incentive payments for improved overall performances. That's where we were tying it to our quality measures, right? To the A1Cs. So you apply for CDC recognition. The Diabetes Prevention Recognition Program sets the standards for the national DPP. They review the standards and the operating procedures and plan for method of data collecting and reporting, which again is highly important. And you can look at if this is the right program for you. And I am seeing a question right now. Please discuss the role of certified diabetes care and education specialists, CDCDS. I often don't see this included in many settings. You are correct. It's not specifically defined, but it is in many of these programs, it is required to have a healthcare professional who is capable of delivering and leading and kind of oversight of these programs. So in the CDC, in the DPP program, I don't know it by heart. I would have to look at it, but I'm going to address it in the DSMES programs that were coming up. So thank you for that.
Maria, there's also another question before transitioning. If you go back a couple of slides, to the graphic where it shows program eligibility, I believe. Why does it say no diabetes and then it says yes diabetes? Yeah, I think it's this one. where it says not diagnosed with type 1 or type 2 diabetes.
So for the diabetes prevention program, you have to be diagnosed with pre-diabetes, but not with type 1 or type 2.
Perfect. And then there was one more. How do you get access to a CDC approved curriculum for DPP?
Oh, the CDC, you can look at the CDC website. There's a lot of information in there. It's very we usually work a lot, collaborate a lot with the American Diabetes Care Education ADCES, ADCDES. They're the organization that we have more experience with working on DPP and DSMES programs, and we have found that their programs, they have access to the curriculum, and they have a lot of support, ongoing support as well, not only setting you up for recognition, but also along the way as a community, even working with other peers and getting that additional support. So I would highly recommend the ADSES, looking at ADSES website under DPP program. And yeah.
Yeah, and I plugged in to the chat. I had already put it, but just in case anyone missed it, I put a resource that we created. And at the very bottom of that, there's the links to what Maria is referring to. There's a link directly to ADCS support as well as CDC support.
Perfect. Yes, thank you, Megan. Megan and I work hand in hand, and I love it that we're always thinking the same. So I appreciate her. And if you become a certified coach to deliver DPP, you also gain access to a curriculum. Yes, you do. And to become a certified coach for DPP, you do have to go through the training, and they have approved training sites that you can only go to those. So that's another thing to consider. But yeah, moving on to diabetes self-management, education, and support. The DSMES, as its acronym is referred to, the interventions include activities that support people with diabetes to implement and sustain the self-management behaviors and strategies. And we have the same thing, right? Behavior strategies, it's defined as lifestyle changes to improve diabetes and other comorbidities that we all know that come hand in hand and that can improve the quality of life of the person with diabetes. So what's the purpose of it? We're trying to make the persons with people with diabetes, we're trying to give them the tools, the knowledge, the skills to be able to themselves be more accountable to their own health and be able to make better decisions, and be able to solve their own problems and to cope better with the whole disease, chronic condition. So it is important that we support them and bring their confidence up in being able to do that. Give them the knowledge, the skills, and that is, in a nutshell, what the DSMES is. It can provide people guidance and knowledge to ask more helpful questions from the clinic and be more present. The benefits of the DSMES. There's no negative side effects. Medicare and most insurance cover the cost. It provides clinical education and support for implementing treatment plans. It reduces emergency department visits, hospital admissions, and readmissions. And if you're tied to a hospital system, you know that readmissions can bring your funding down. So readmissions is something that you have to work on reducing. Again, those quality metrics, and then this supports that. You reduce hyperglycemia, reduce all-cause mortality, lowers the A1Cs, and improves blood pressure and cholesterol levels, improves medication adherence. So a lot of times we don't think of our pharmacists, and just like there was mention of the CDC, the certified diabetes educator specialist. we also need our pharmacist on board if we have one, or our local pharmacy. Not even really, like, we have sometimes need to look also outside of our siloed compartment of health or setting, right? Our work setting. We also have to look at, if we don't have a pharmacist in our health center, then let's look to the pharmacy in the local town. They're a valuable resource, and pharmacists can lead this effort as well. Improving medication adherence and knowledge, which we all know that diabetes has such a high component of medication issues. So it promotes lifestyle behavior, including healthful meal planning and physical activity, address weight maintenance and loss, and enhances self-efficacy and empowerment. And I think that these are not only, we're looking at this benefits and trying to make them so that it's not temporary, right? That takes longer. It's not a magic pill. It takes longer to get to those, but they can be more sustainable in the long run, improving the quality of life altogether for our patients. So it also aligns with the national standards of the DSMES. The national standards are reviewed every year. They outline the latest evidence for effective and sustainable DSMES service. They provide a roadmap for practitioners to implement the DSMES service across different practice settings, and their aim to ensure quality, again, that quality improvement, and they serve as for accreditation. So you do have to know your national standards and be aware of it. As healthcare professionals, we also have to be keeping up with our own education, so that we can continue to support our patients accordingly. So it's based on the 6 standards. Before, this used to be 10. So there has been a huge improvement and effort on their side to make the standards easier and less burdensome, I would say. The first 3 are mainly the structure of the service, the support, and who is going to be doing the service. So those are the first 3 standards. Then you have standard 4 and 5, which are actually the service that is going to be delivered. And then you have standard 6, which is always the last, but I would say very important last one, which is going along with the outcomes, and probably is gonna be your method of sustainability as well. It's gonna give you that sustainability. It's patient-centered care. So strength-based and inclusive language. At NCFH, we're always looking at creating tools that have the right language and they're culturally adequate for the population that we're serving. Same thing here. We're looking at the patient, reducing the stigma for people living with chronic diseases, and peer support. We want to empower people. So, as I said, we work closely with the American Diabetes Care and Education Specialists Organization and ADCES, ADCES, as others might say it. It has this really good visual, which I really like, with really that patient-centered core, taking the core as a patient and wrapping around them and building around them the different self-care behaviors that need to be worked on. So you have healthy coping, being active, staying that physical activity, that eating, the medication, really important, and monitoring, also another important factor, and giving them the tools to be able to problem solve and therefore reducing the risks. So it's all very wrapped around each person. When is DSMES recommended? For critical times, sorry, I missed the times there. For critical times to refer to DSMES are one, obviously, when they're diagnosed. So people are really overwhelmed when you're first given a diagnosis that you have diabetes. So that is a good starting point to start getting the patient into that into those self-management skills. Then you have another opportunity annually or when you're not meeting target treatments. What you also want to refer patients when they have complicating factors or when there's transitions in life. So, for example, think of when a patient has an additional complicating factor that may affect their handling of their day-to-day diabetes care, even though they know their self-management, maybe they got a cut and they have antibiotics and they have a complication from it. And their blood sugar levels are all over the place from then on. Something also like cancer diagnosis that can change medications, that can change so many different things, emotions or coping. So those are the moments where a patient may need additional DSMES, and it's recommended to be referred to that. Also, life transitions, right? So whenever you have, you're moving from one city to another, everything is new. You don't know where your pharmacist is. You don't know, you don't have your usual healthcare team. That's another life transition that may require DSMES. What is the accreditation cost? The same thing as the DPP program. We do work closely with ADSES, as I mentioned, and the cost, this is for ADSES, for one, for the first main site is $1,100, and then there's two different concepts, which is additional branches or additional community sites. The difference between them is whether or not you're billing with one or many billing IDs. So if you're using only one billing ID for all of your locations, then they're considered community sites and they're free. If you're billing with different billing IDs, then they're different, and then there's an additional charge as a branch. There's also their accreditation is valid for 4 years, and there's the renewal application fee structure, which is similar. The accreditation application is all done online. And ACCESS has their website with a deep portal in depth. It's diabetes education application port. The portal and its supporting documentation requires include completing an online application, uploading any supporting documentation, and completing a virtual orientation. And there's actually we have gone through this process with several health centers in the past, and we want to share that it's such a seamless process. They are so supportive, and really the process is flawless. If they see something that you put in the application that does not make sense to them, or they need additional information on, they will require that. They will contact you and address that together with you and work with you on it, instead of denying the application. So don't be afraid. They really want you to be able to offer the DSMES and be able to be a sustainable program. They also have a lot of templates, if I might say, that they have templates for each one of the steps of the supporting documentation that they require. So if you don't have it, you can use theirs and just fill it out. So it's really useful, a really good system. The process of completion, you do have to have one patient, a record of one patient that already completed the entire DSMES intervention, and this needs to be documented. The applications are reviewed within 2 weeks after completion, after a full submission, and accreditation timeline varies depending on questions or how complete the application is. The program selects one clinical and one behavioral outcome to be reported annually to ACCESS. And here is also another point where I would tie it to your clinical metrics, right? You're already taking those clinical metrics, those A1Cs, blood pressure, and one behavioral outcome may be something that you're interested in, maybe medication adherence or whatever it is, but tie it to your actual health center's goals. They do have a lot of support. And I think the slides tells it all. You have a community within ACCESS that you can have. The accreditation piece also opens up for your health center to be able to bill for the DSMES. Why is this important and why is this here? It's because that sustainability piece, right? So as a health center, being able to bill for the service adds to that sustainability of the program. And you are allowed to bill for Medicare in some states. Medicaid, you have to look at your own state and see whether or not you can or cannot bill for, and the private insurance also pay for the DSMES. Again, on a case-to-case basis, I imagine. The accreditation, the referral process, the DSMES does require a referral, different than DPP. They do require a referring physician or non-qualified non-physician practitioner. So a CDCDS can be the referring. So that's where that comes in. The order of the DSMES services must include a statement that services are needed, the number of initial or follow-up hours ordered, and the topics that must be covered, and the determination of individual or group DSMES service. Health centers, for example, can only bill for individual DSMES service, not for group settings. So that's something to consider. The DSMES provider must maintain documentation of the original order. So that referral is needed within the process. And NCFH created a pharmacy-led DSMES guide. And you can use the QR code in there, or Megan also shared the link to it as well. You can download it. I know it says the pharmacy-led DSMES, but don't be afraid of that. You don't have to be a pharmacist to go through this process. And as I said, and at some point during today's presentation, a pharmacist is an excellent person to bring on to your DSMES efforts, and but not necessary. So you can look at it. It does have the differences between the ACCESS accreditation and the ADA recognition, which are the two different entities that can accredit for DSMES. And it goes over the cost, the initial application, accreditation process, renewal, and at the same time, it goes over all different 6 standards. And take into consideration, the standards are all the same for both processes. So they use the same standards, right? They use the same standards for both accreditation and recognition. If you need additional support for our technical assistance, or if you have additional questions that maybe we can jump on a call with you and have a 30-minute, 1 hour a conversation about, and link you to those resources that you're looking for, or help you determine what's the best program for you, that would be something that we would greatly appreciate your request from us, and we would be really glad to help you with. So reach out to Megan Martinez or myself. You're gonna have my email also at the end of this presentation, and we would gladly meet with you and work with you. Megan has supported different health centers in getting their accreditation, and have been successful at doing so, and we really appreciate and love working with health centers and other organizations to increase access to DSMES and DPP. So we also released a poll because we want to learn a little bit more about your healthcare setting, if it's a health center or not. Do you have DSMES? Are you an accredited or recognized program? And would you like additional support? Greatly appreciate you filling in, and we'll give you some time.
Maria, as they're answering the poll question, there was another question. Whenever you were talking about billing with DSMES and all that, what about free clinics? What if they become DSMES certified? What do they have to bill, or if they're free?
They don't. This can be a free service. The health center or the clinic can decide whether to bill for it or not. So yes, they can be accredited and not bill. And some health centers and clinics, they bill whenever they can, and they still give the service to those who are uninsured, and there's no payer picking up the bill, and they don't charge the patient either. So it can be depending on each organization's policy, but it doesn't take away your accreditation or recognition, whether you bill or not. Hope that answered the question. So I cannot see the polling. Oh, thank you. So yes, a lot of you have the DSMES, but others don't. So it's a bigger percentage that don't. So, and the same for accreditation and recognition. So one of the things that us as healthcare professionals working in diabetes almost never do is recognize everything that you do. You're already doing so much, and an accreditation or recognition can give that validation to the program, and at the same time, you're already doing it, so why not get it and get the recognition and accreditation, and enhance your program. We have to seek for ways to enhance our program, enhance our services, and as it was stated at the beginning, this problem is only getting bigger. So the more help and the more support we can get from our healthcare partners and co-workers, that's amazing. So look at it that way, and maybe if you're interested, send us a message. We also have our Diabetes Resource Hub, which has a lot of different materials that we have created over the years that we have been working with in the diabetes area and pre-diabetes. So we have all those available for you there. And again, my name is Maria Bustamante. Please reach out either to Megan or to myself, and we would gladly look for a way to help you or connect you. Or if we don't have the answers, we're going to search for it and connect you to those who have. So